Kieran, it's wonderful to have you, and you're going to give an update on the national primary care developments in chronic pain. And as a GP advisor to the Scottish Government, we're looking forward enormously to hearing more. Are you able to load up your slides, Kieran?
I'll try.
Thank you.
Can you see that okay?
That's brilliant. Thank you. And over to you now, Kieran.
Right, okay. Right, fingers crossed. Yes, can everybody see that? I'm assuming yes.
Yes, we can.
Right, perfect. Okay, my screen's just the presentation. So if I'm going off piste or you can't hear me, someone say something. But that's fine. I've got the links here, so I can start. I'll be as quick as I can because I'm aware of time. So first of all, thank you for having me. It's a pleasure to be here. I'm coming from sunny Blantyre in Lanarkshire, and my kind of talk today is on the role of national primary care developments in chronic pain, and I'm very happy to share that with you. I am part of a team, just like everyone, and here's some of our national colleagues, a lot of whom you'll know, and a special shout out to Emma Mayer, who's just finishing up with the team, and I just want to say thank you to her and all the work that she's done. It's been a complete pleasure being her colleague and her friend as well, and I've learned a lot from her and wish her all the best. There's other people involved. Nicola's already spoken, and you'll recognise the names of Professor Blair Smith and Paul Cameron as well. So it's been great to be working with them. And really, you guys know a lot more about chronic pain than me, I feel, but this is an overview from the core standards of faculty pain medicine. So whistle-stop tour and some NHS Scotland data. We know that chronic pain is a big deal. There's a high disability, there's high problems with age and deprivation. 60% of working age adults with severe pain are unable to work. And NHS Scotland data, there's 26 million general practice consultations a year. And what we're seeing is that with people living in pain, it's a 5-fold increase in the rate they attend their GP. And that works out with recent data about 1 in 5 consultations have got a chronic pain element to them. There might be more than one thing in the consultation, but chronic pain is a part of it. I've already had 12 consultations this morning, and I can certainly say it feels like that. In terms of analgesia, well, we're spending 128 million on them a year. We know they're limited and often can be harmful as well. And we know that people living in pain, about 2% attend a chronic secondary care pain team. And I think it's around about half of those with severe pain attend the secondary care pain team. So it's a big deal, and a lot of it lives in primary care. But we need each other, and that's why I'm here today as well, to hopefully strengthen that. So our work is influenced by the Scottish Access Collaborative workshops, and we have to, whatever we decide or plan, we have to have sustainable planning and sustainable funding and a sustainable workforce. But within that, I think we have to strengthen a primary and secondary care interface, the relationships and measurement data, and of course improve patient empowerment and self-management, supported self-management, and new pathways that make it easier for people. Another way of looking at it is there was the chronic pain survey from 2020 across primary and secondary care, people living with pain, third sector, and there was about 300 respondents. And what they did was which I think this is really nice, it's a word cloud of what people thought collectively could be improved the most. And you can see access is the thing that came up top there. And then after that, there's lots of themes of support and different people. And so really for me, I took out that access and support is what people are looking for. So what we've moved into now is this idea of skilled practitioners, trying to promote the role of skilled practitioners so that people get access and support earlier in their pain journey. And people will be very familiar with the sort of national framework of the model of care, and level 1 in the community, level 2 primary care, 3 pain teams, level 4 highly specialised. And we're just trying to strengthen that sort of level 2.5 idea to meet the need, and really alongside that, the things that I've mentioned, interface with primary and secondary care, effective prescribing, better education and training and supported self-management resources in the workforce development. So this is our work plan. It's pretty broad. I could talk all day about it, but an overview is that number one is it's the pain management expertise in primary care. So we've got projects that we're promoting. We've got level 2.5 pain team, kind of primary care team meetings, learning from each other, consultation skills, trying to develop that as well. And then the interface, we've got the projects that I'm going to talk about. We've got Pain Team Scotland, which is a Facebook page. Any clinician in NHS Scotland is welcome to join that, because we've got primary and secondary care represented there, and it's a place for learning and support. And then we've got educational models across services. Local services are innovating and we're learning from that. We also want to support effective prescribing. So we've had conversation with the highest deprescribing GP practices in Scotland, learning from them. There's a toolkit we're putting together with realistic medicine themes and links with prescribing work streams. And then we've had a high emphasis in education as well, in public health messages. So we've had outreach to North British Pain Association and RCGP and other kind of primary care events, and trying to learn with NES as well, and looking at training programs as well, and also looking at remote healthcare pathways. Here's an overview of the projects that were selected from last year. I know that colleagues here will see some presentations and agenda, so it's wonderful to see that integrated in today's event. And it's really a privilege to see this information. And what we're seeing is teams in primary care, teams in secondary care, interface teams, third sector as well, using IT, using skilled practitioners, sometimes pharmacy, sometimes physiotherapy, sometimes psychology, but really looking at ways to see what works and what's sustainable and scalable and what can we learn. And the key thing from these test of change projects is learning. So with that said, what have been the learning themes? I think the first thing is the pathways. So again, earlier intervention, wider teams, shared access to self-management, and a realistic medicine approach, on open and honest conversations, and effective prescribing. And for the service providers, we're looking for increased clinician confidence and competence, relational care as well, so that better conversations with people and more awareness of psychologically informed practice, stages of change where a person is in their own pain journey. For the service user, we're looking at supported self-management skills, access to wider resources, being involved in their own care and personalised management plans. And challenges, again, it has to be sustainable funding and workforce resources. We have to be aware of inequalities, digital divide, cultural issues, and we have to see what is the kind of sort of validated data and measurement tools. And it's 2021, we're in a pandemic, so the pandemic's been a big fat part of everybody's life. So this is where we are now. It's very exciting. We've got projects that have just come in. We've been having lots of conversations about them, and we should be in a place to send out letters very soon to give those colleagues feedback. So 18 applications across 10 health boards. Let's say the quality has been very high, and there's an emphasis on skilled practitioners, the interface, primary and secondary care, and widening teams. And really, I suppose it's just an idea of what would a primary care MDT look like. Well, it would be have the patient at its core, and it would have key themes, and it would be earlier diagnosis and rehabilitation, good conversations, safe and effective medicines management, and improved outcomes that would result in reduced demand on GP time or secondary care or hospitalisation. And here's a sort of example locally, just kind of real world case studies. So this is occupational therapy and NHS Lanarkshire, a test of change project. So there's now 18 practices covered, and there's pain data, crude data that we've got back from 6 practices, and that represents about 140 patients. And what we're seeing is that 1 in 3 of those patients have derived significant functional improvements in quality of life with OT support. So what that looks is like is people staying in work, returning to work, staying functional, remaining independent. And what we're seeing as well that's really encouraging is that cuts across and is actually emphasised more with SIMD1. So it's helping to address inequalities. And professionally, as a GP with an OT in my practice at the moment, it's been very satisfying to prescribe access to a skilled practitioner rather than a drug. So it gives us more options. This is another bit of work that we've been doing. So it's person-centred deprescribing GP practices. So there's 950 GP practices in Scotland, and about a year ago we asked Public Health Scotland to run a search and say who's got the highest deprescribing of gabapentinoids and strong opioids, so starting from a high, above average to below. And we were able to get that information and then contact those practices and have good conversations and learn from them. And you can see that we've got case studies now from 6 practices around Scotland. What's interesting is that there's different themes that come out, but there's definite core themes that they all share. And I think the first thing to say is, first, do no harm. I've had 12 consultations so far this morning. I've already told one person it's dangerous to be on these medicines because they're on so much other stuff. So I think that front loading with the principle of first do no harm, especially if someone's at high risk or if they're in high doses. And then the next thing I would say is look at data and reflect, have a quality improvement approach, culture change from painkillers to pain management, doing it as a team and having a consistent message to patients and colleagues, and then a medicines management system so that's based on safety and effectiveness, doing drug trials, and if it doesn't work, then don't take it. And educational resources as well, and should have said working in partnership with patients I think is really core in this. And of course, if people need more than information, then access to support and a skilled practitioner early in their journey, as we've talked about. Pain team collaboration, so out of our 6 practices listed there, 3 have got very good working relationships with their pain teams, and I think it'd be lovely to see more of that to strengthen that interface. And all the practices think this is a public health issue, so that there should be more awareness generally that chronic pain or persistent pain is a long-term condition. So this is another case study. It's our own practice. It's where I'm sitting at the moment. And so we are 7,000 patients, SIMD2, so relatively high deprivation. Our mindset has changed. We see it as a long-term condition now. We've got a team in continuity. We're having kind of realistic medicine-based consultations and using what matters to you in people's lives. And the pain team, for me, is the person and their family with ourselves, with our team, and pharmacist or OT or whoever's available, mental health nurse. I don't have a physio, but if there was one, I'd definitely involve them as much as I could. Third sector specialist pain teams as well. And the outcomes for us is that we've got over 250 people now in our chronic pain register. We've got better relationships with them, reduced consultation rates, average 2 to 3 times. Someone will come and see me about it, and we've halved our strong opioid and gabapentinoid prescribing since 2016. We're above the Scottish average for both, we're now below. And we've halved our pain team referral rate, we're in the lowest quintile in NHS Lanarkshire. We've got significant cost savings from medicines, but really it's the value for me is the improved quality of life for patients and professional satisfaction, and that is priceless. So thank you very much for listening, and where the time is tight, so I've got my email there, but if anyone wants to ask, that's fine. If there's not time, that's fine as well, but feel free to get in touch with me. Thank you.
Thank you, Kieran, for a lot of hard work there and your reportage to date. Are there some questions? I can see a few things coming up in the chat. Can I ask, are there some groups of patients, this is a very obvious question, that actually find their treatments inappropriate with strong side effects, and you cannot get them off the drug because of their good quality analgesia? Are there some resistant patients with particular diseases or conditions, in other words, like neuropathic pain versus some of the inflammatory pain states?
So the question is, are the people who are resistant that are kind of stuck?
Yeah. Is
that right? Absolutely. Yeah. I had a man yesterday, 34, opioid hyperalgesia syndrome, and he's stuck, and that's been with everybody's feedback and pain team support. And there comes a point where you have to be honest. I think that's the key thing for me, is treat people with respect and be honest and do what I can, but I'll explain what I can't do as well. And even this morning, about 45 minutes ago, I had to say to someone they would die if I gave them more analgesia, because they're already on 15 milligrams of diazepam, clonazepam, zolpidem, and this and that, and you have to be really upfront. But at the same time, you say, I know you're suffering, I believe you, and I want to work with you. So for me, it's hearing them, validating their suffering and supporting them, but at the same time there has to be honesty going through it.
There are some forms of pain that appear to be much harder to treat. Leslie Colvin is asking, how do we focus on appropriate prescribing rather than de-prescribing?
I think it starts with the patient always, and I think for me it's about giving people information and what they, knowing the numbers needed to treat, knowing the awareness of drugs and being realistic about that there isn't a painkiller, painkillers don't exist, that at best they give some relief in the person's pain. So for me, I think that realistic conversation at the start, so that there's expectation management. And again, if it's based on improving someone's quality of life and function, so that we do drug trials and they improve, then fine, and especially with no harm. So for me, the best medicine is the one that's got the best improvement in quality of life with minimal side effects. But at the same time, I'm aware that we do have a massive problem and we have to be honest about that. And so absolutely patient-centred, drugs have a role, but for people to be fully informed in it. And then if they're not effective or they're causing side effects, we have to be honest about that as well.
Thank you. And David Walsh is asking a question. An excellent achievement, he says. De-prescribing has become something of a mission with very good reasons, but there is also evidence that medications can be helpful. How big an impact on quality of life does this process have? And does it reach NICE's 20K threshold?
I mean, I think one thing I would say is, I think the role of antidepressants, I think it's so easy to miss the emotional component of the pain. I mean, as a GP, we're in a 10-minute system and it's so complex and it's overwhelming for colleagues. So I think that being able, probably if I was saying to colleagues, fellow GPs, I would say this is a long-term condition, take your time and build up relationships with patients, and then actually, promoting drug trials, but also the emotional component, the pain as well. So that for me would be effective prescribing and getting maybe baseline information.
Right, on that note, maybe I should finish. I hope that answers David Walsh. The system here doesn't allow audience members to speak, so we're going to have a short break, and Jackie has very kindly said, let's start again with session 2 at 12, if that's okay for everyone. So thank you so much for all the contributors, and thank you to the audience.